Good evening, everyone. A warm welcome to all of you for today's masterclass on PREM and PROM in quality healthcare, organized by IIHMR Bangalore. Very happy to have participants from diverse backgrounds who have joined us today to gain insights into this masterclass, which is highly relevant and much needed in advancing the quality of healthcare delivery. So, once again, a warm welcome, all of you, and a special welcome to our program coordinator, director, and resource person. So, I'd like to take a moment to introduce our program coordinator. So, Dr. Deepashri, Assistant Dean, Academics and Student Affairs, Faculty in charge for trainings. Dr. Deepashri is a healthcare management professional with a background in Ayurveda, holds 10 years of experience. She has completed training in continual quality improvement, tools and techniques QCI, and implementation of 5th edition NABH standards in healthcare institutions. She successfully executed entry-level NABH accreditation for MBA Hospital and full NABH accreditation for Dr. Chandrama Dayananda Sagar Medical Education and Research, Harahalli. Currently, she is leading our NABH projects under the NABH wing of IIHMR Bangalore. Ma'am is trained in quality tools and techniques by QCI, implementation of NABH standards. I'd love also to extend a warm welcome to our program director, Dr. Usha Manjunath ma'am. Ma'am holds a PhD in management from BITS Pilani and an MPhil in hospital and health system management. With over 25 years of experience as a management faculty member, her expertise spans healthcare, behavioral science, quality management, and entrepreneurship. She is the author of Total Quality in Healthcare, a National Quality Assurance Scheme Assessor, and an ASPPH Leadership Scholar. Her accolades include Paul Harris Fellowship recognized by Rotary International, India's 20 pragmatic women leaders in higher education, Bharat Ratna Indira Gandhi Gold Medal, and from AIMS, Outstanding Editor Award, H Index 7, I-10 Index 6. It's my privilege to extend a special welcome to our esteemed resource person for today's session, Ms. Meenakshi Anchalia, Healthcare Quality Assurance Leader, Mentor in NABH and JCS Standards, FISQA, Certified Professional, Patient Safety and Quality Advocate, Healthcare Strategy and Policy Expert, Project Lead Administrator. She's a passionate healthcare quality leader. Her mission is to empower hospital to deliver safer, patient-centric care through accreditation, standards, compliance, and system redesign. Ms. Meenakshi have mentored over 80 plus hospitals across India in achieving NABH, JCI, and ISO 7101 compliance, driving measurable improvements in quality and safety. With a strong foundation in FISQA, process excellence, and healthcare leadership, specialized in transforming policy into practice, bridging clinical and operational and strategic grounds. I welcome you all once again. Over to Deepashri ma'am for our introduction to IIHMR.
Thank you, Pavitra. It's my privilege to introduce our college. Let me take a few seconds to share the screen. Yes, probably my screen is visible to all the participants.
Yes.
Yeah, we are ourselves as Institute of Health Management Research, Bangalore, established in the year 2004 with the 20 years of legacy. This college was set up as a response and the need for in the South India regarding the healthcare management and hospital management. We have three sectors. We are three working in health management education, research and consultancy, and training programs in health and related areas. The key verticals of our institution is academic, research and consultancy, training, and Center for Advancing Digital Health, that's we call as ADMIRE. Coming to the key milestone achieved by our organization, we have initiated our work in 2004, achieved AICTE approval for the program, flagship program that's on PGDM in hospital and healthcare in the year 2010. I got an NABET accreditation as the first South Indian academic institution for quality consultation and training. In 2017, as a response to the need of digitalization in healthcare, we started a new specialization in health information technology. In 2018, we got MBA equivalents for our flagship program by AIU and NBA. A new specialization on pharmaceutical management and the extent of the seats from 60 to 120 was started in the year 2020. To a new vertical, which is Center for Advancing in Digital Health, was started in the year 2022. A new program, which is a fellow program in management, equal to the PhD, was started in 23. 24 was a new program era where we started PGDM in AIDS in healthcare, first of its kind in India, and a NAC accreditation in the year with A grade in 2025. Coming to the academic programs, we are affiliated with AICTE. We are awarded MBA equivalence by AIU, accredited by MBA, and NAC accreditation with A grade. The programs we offer as PGDM in hospital and health management with specialization in hospital management, health IT, and pharmaceutical management. We were the first one to launch PGDM in AIDS, that's artificial intelligence and data science, in the field of healthcare. And we are successfully running the second year for it. We also have started fellow program in management and also an executive program in hospital management, especially for the working professionals. Our curriculum is customized to the industry requirement and a right mix of industry and academia interface. So this is the academic program at a glance. And we have received different awards and recognition. We have recognized as the 10th B School in Bangalore, Outlook in 2025, and Mirchi Business Class Award for Excellence in Hospital Management and Digital Healthcare Innovation in the year 2024. Our students not only are in the academic, but also they participate in general healthcare awareness among the nearby communities. And these are the few glimpses of the people working in the diverse and dynamic environments. We, as a research institute, IIHMR Bangalore has an expertise in implementation research in large-scale surveys like CAPI, and also using the CAPI like NFHS 6. We were part of NFHS 6, and we are also take different projects on monitoring and evaluation. The thematic focus for our research is health system strengthening, nutrition, NCDs, RMNCH+, plus urban, rural, and tribal health, and IEC and social behavioral change communications. Center for Learning and Development is a third wing of IIHMR Bangalore, where we conduct different kinds of training programs, skill building programs, after analyzing the requirement from the stakeholders. And we do offer long-term, short-term, and management development programs, faculty development programs, as also well as student-focused training programs. The upcoming programs which we would like to highlight is we are starting an executive program in digital healthcare and smart system, and that we are successfully running for the third cohort in collaboration with University of Oslo and HESP India. We are also having upcoming workshop on mastering a proposal writing, especially for the public health aspirants and NGOs who are willing to get a successful proposal. They can participate in our workshop on a proposal writing. Next, we have a certificate course in health financing. It's a 3-month course, again, starting in the month of November. And also we have a workshop on healthcare sustainability in management. It deals with economics and the circular economy practices in healthcare. This is a 5-day program, and it's a workshop which will be organized in the month of January. Do connect back with us if you're interested in any of these programs. Coming under NABH and quality consultants services, we were the NABET accredited organization, and also we are empaneled with NHA, that is National Health Authority, to improve the quality standards and healthcare facilities in India, in Karnataka. We do take up accreditation programs. We do take up NABH accreditation, full entry level and re-accreditations for hospitals. We also have a accreditation maintenance program where we help hospitals to submit their quality indicators, quarterly reports for accreditation, and staff sensitization about accreditation standards. and also quality and patient safety programs, which is conducting a clinical due diligence, clinical audits, develop a safe hospital design, communicates safe information, safety information for the patient. So these are the few programs, services we do conduct at consultancy services. Recently, IIHMR has been recognized as a Gunavatta Pathshala champion by NABH, a part of QCI. And the fourth wing of IHMR is Admire, that is a Center for Advancing Digital Health. We have four categories in that, where we do conduct research and development in the field of health informatics, clinical informatics, and consumer health informatics. We also have a skilling hub where we conduct, we train a workforce on digital health. May we make the workforce ready for the digital health, and several boot camps and technology expertise we are having under skilling hub. We also have an Digi Health Data and AI lab where we are supporting with a startup has an incubation center and testing the algorithms in the digital health. And also we have an incubation where we are fostering innovations and digital health. As of now, we are supporting around 7 incubations, which startups in Bangalore, and helping them with the funding aspects. IIHMR also have a strong relation with the government. We are partnered with NHSRC as a knowledge partner. We have empaneled with NJJM, that is National Jal Jeevan Mission, has a key resource center. And also we are empaneled with the Karnataka Monitoring and Evaluation Authority, which where we got the government projects, evaluation of the government projects. And these are the few strategic collaborations we have done through the 20 years of our legacy. We have government institution, academic institution, learning and developments and organizations, health and medtech companies, and healthcare delivery system who have partnered with us for our academic and training activities. This slide represents our intellectual capital. We do have a right mixture of multidisciplinary team in our IIHMR Bangalore. We have professor, associate professor, assistant professor, with a mix of from finance to statistics, from nutrition to public health. So we have a right mixture of multidisciplinary team who can help you in the research and implementation program in healthcare organization. Thank you so much for time and patient listening about IIHMR Bangalore. Do connect back with us for any of the needs in healthcare industry. Thank you. Over to you, Pavitra.
Yes. Now we'll have a pre-test questionnaire part. So I'm posting the link in the chat box. So I'd request all the participants to take it. Kindly requesting all of them to fill the pre-test questionnaire. You can take 5 to 10 minutes.
So please click on the pre-test link. Let us know if you have any challenges. This would help us to grade ourselves as well as it will grade you. So please click on the pre-test link and let us know if you have any challenges in that part.
Requesting all the participants to take. We are receiving only few responses.
Requesting participants to put a message that you have submitted. It helps us to start the program. Okay. I think Pavitra, you can reshare the link because newly joined may not see the link.
Sure.
Yeah. Those who have joined now, please take a pretest. The link has been shared in the chat box. Uh, Pavitra, I think it's time. Let's give time for Meenakshi ma'am.
Yes. Over to you, Meenakshi ma'am.
Thank you very much, Dr. Deepashri and Pavitra and IIHMR for having me here. A very good evening to all the participants and thank you all for joining. So I will not be in between the session and you. I'm just trying to share my screen. Let me know if the screen is visible and if my voice is audible.
Yes, ma'am.
Yes, great. So is it okay? Shall I begin, Dr. Deepa?
I think yes, ma'am. Most of them have done with the test. We have received the responses. I think we'll not wait much.
That's great. Thank you very much. So, thank you very much for registering for the session on PREM and PROM. So, these two words are the most frequently and commonly used words. And to be very honest, these two words have seen the light in the last 2.5 years at the maximum. So, it's I would like to keep the session a very interactive one. So I just want to, I want you all to comment in the chat box whether you have heard these words before the last 2 years or it's a new word for you as well. For me, it was a new word for the before the last 2 years. So you can just put a comment in the chat box saying, is it a new word or it's an old word? New word, yes. And there is a very, very huge similarity between the two, except for one alphabet and one word. PREM, we are only talking about patients. PROM, again, we are only talking about patients. But the one word which is differentiating, the one letter rather, which is differentiating PREM and PROM is E and O. One talks about the experience, the other talks about the outcome, right? For example, if I have to put it in a layman's word, experience. So, what is your experience in attending this particular session? And then, what is your outcome after this session? As in, how you have applied it, or what are the takeaways you have actually had from this session? So, to begin with, PREM and PROM, patient reported experience measures and patient reported outcome measures. These are the two very, very simple words. Okay. Now, what is a PREM? PREM is nothing that will be talking about the patient's experience. And this is all I'm talking about the healthcare journey, and I'm going to give you loads and loads of examples about the health from the healthcare fraternity and the healthcare scenarios. Okay, when you're talking about experience of a patient, it is nothing else but the communication. How are you acting to the patient? What kind of a response are you giving? How much are you involved in the decision making? And how much are you satisfied with whatever experience you have had in that particular healthcare setting? Whereas outcome is how the experience has led to your outcome. How are you, capturing the patient's experience and then converting it into the outcome? That is the symptoms, the health status of the patient. What is the quality of care that you have given while the patient was admitted, which is resulting in the quality of life after the healthcare intervention was done. So experience is mostly in the hospital setting, whereas outcome is once the patient has got discharged and probably 2 months after that, and then 6 months after that, and then 8 months after that, and then probably a year after that. So what is the outcome of that particular patient? So patient reported experience measures is the tool that captures the patient's perspectives on the healthcare journey, whereas the outcome is something that captures the perception of the healthcare status, symptoms, etc. after the healthcare intervention is actually done. Okay. Now, why does PREM and PROM matter? Why do you think we've been talking about PREMs and PROMs in the last 2 years? Because it is a measuring tool. It is very, very instrumental in measuring what actually the patient is achieving out of the clinical success. So here the focus of the patient shifts from the volume of care to the volume of to the value of care. So how many patients the hospital is treating till what care is the hospital giving. So here if you see, volume of care is nothing else but how many procedures you've done, how many admissions you've done, how many inpatient days you had, what was the length of the stay of the patient. All these are your volume of care. But the value of care, how many patients, how was the experience of the patient? What was the outcome of the surgery that you did? What was the outcome of the patient who did a TKR, a bilateral TKR, and is walking without a stick, and now is probably leading a normal life? A driver who was continuously driving had a TKR in your hospital, and now after 2 months he's properly walking, and rather he started going for short distance drives also. So that is what is the outcome, and this value, whatever you are measuring, this is a measurement tool. This whatever you are measuring is actually going to be used for the benchmarking. And nowadays, in the US and in even in India and abroad both, you see there are a lot of reimbursements which are linked with the PREM and PROM experience, or rather the feedback. We were always talking about the feedback, but we never talk about individual patients' experience and outcomes. This is what it is now. And now the benchmark is, what is the benchmark that we are having now till the measurement of the benchmark from the industry standard. So that's the gap that we actually have to fill, and which is why PREM and PROM are measured, and it's actually a value-based healthcare measurement tool. Now, why do it matter? It also matters according to your accreditation agencies. Now, if you see in the sixth edition, they're talking about PREM. They're talking about the continuous quality improvement. And how does your patient feedback match with that of a patient's experience and outcome? So NABH is now talking about PREM and PROM in details in the sixth edition. JCI is now talking about the patient-centered communication, whether you're taking the informed consent from the patient, how is the outcome of the patient, and what are the supports and the compliance that you're giving to meet that particular outcome. So JCI is also using it right, left, and center, and WHO is definitely using it because they're talking about World Patient Safety Day, they're talking about the patient safety strategies, they're talking about engaging patients. Now, the next in thing in the hospital is something called the Patient Advisory Committee. Now, what is the job role of this patient advisory committee? Is to basically have patients as a part of the pool and get their experiences and their outcomes measured and tap it with that of the quality of the care that you are actually giving in the hospital. Okay, so you must be now the third word, which is actually seen the day, is PAC, which is the Patient Advisory Committee. But we will not be dwelling more into that. I will be taking you through the PREMs and PROMs. Now, how does PREM and PROM matter towards the patient safety culture? They detect the unsafe systems very, very early. If there is a poor communication, if there is a miscommunication, immediately then it will be flagged. Okay, and the PROMs reveal the hidden arm, which is functional deficits after the successful treatment. So now, the difference between PREM and PROM in the patient safety culture. If there is a miscommunication, if there is a delay in the discharge process, if there is a wrong surgery at the wrong site at the wrong patient, or if there is a delay in the IPE billing, it's all flagged very fast nowadays. And PROM, which is after the patient has got discharged, you understand how successful the treatment was, and now it's no more the word of the mouth, it's actually the other way around. Okay, so outcomes, no matter whatever outcome the patient has, no matter whatever reviews you are writing, if you're measuring the outcome and if you're publishing any papers out of it, that's nothing like it. Yes, so together prems and proms strengthen the culture of transparency, accountability and safety in the organization. Now there's something which is the quality pyramid. Okay, I haven't made it as a pyramid, but it's just the layers that I'm talking. The base layer is actually quality, which is governing you with all the evidence-based protocols, your clinical governance, your clinical guidelines. That includes your CDC guidelines, your NACO guidelines, as far as the quality concepts are here. Not related to the infection control, but overall quality. The second layer talks about the safety. So after you have actually established the quality in the organization, you talk about establishing the safety standards. So you talk about preventing harm, you talk about preventing the near misses, you talk about medication errors, you talk about prevention of adverse drug events, you talk about prevention of any medical errors or anything. Yeah. So after quality comes your safety, and then with the safety will come your third layer, which is your outcomes. Now, once you have seen the safety concept is embedded, then your care bundle comes into the picture, your CQI comes into the picture, your page PSQ comes into the picture, where you're talking about the different outcomes, which are both clinical and non-clinical. Here I am giving you examples of clinical outcomes, which is your mortality, morbidity, your infection rates, your hand hygiene compliance, then your biomedical waste, then your needle stick injuries, all these will be your outcomes. And then the top layer of the pyramid is actually the patient's voice. So it's quality, safety, outcomes, and finally the patient voice in the form of PREMs and PROMs, which is your experience and outcomes. Therefore, completing the picture of true healthcare quality. So when we are talking about quality, as you know, NABH says, quality is not only NABH, any accreditation body would say quality is an ongoing journey. So once you have actually started your journey, then comes the culture of safety, then comes the outcomes that you are having after establishing quality and the safety, and then comes the patient voice. So the patient voice is the peak one. You might go to a very small nursing home, but if the delivery of care is excellent over there, then the word of mouth, anybody in a small town of a in a small three-tier town will also know XYZ hospital is known for laparoscopy. So the patient voice is that is speaking there. But they, for all you know, might not be capturing any feedbacks, any prems, any outcomes, but that any prems or any proms. But the word of the mouth is what is actually the top of your pyramid, where you see the patient voice is that what matters. Now, this is a very interesting slide. I I will wait over here. I will pause for a minute, and again, let's anticipate. And I would request you to unmute yourself and answer what is this plane accident I have kept here. Then I have kept a picture of a car accident, and then I have kept a picture of a chest X-ray. Yes, please let me know. Unmute yourself and let's make it more interactive and tell me why have I put this picture here and what is the relevance that it has. Yes, anybody can unmute yourself and talk, please.
I think the third X-ray points out to medical negligence.
Yes, it does.
And maybe the first two, some infrastructure related, if I'm not wrong.
Okay, good try. Somebody else, please.
Ma'am, it will tell about the patient-related accidents which happen as a part of a medical error. So the incidence of plane crashes 1 in 29 lakhs. The car says 1 in 5,000, but the medical error is 1 in 300, which is a very big number as such.
Very good. Somebody else, very nice attempt, Lakshmi.
But
Somebody
due
else.
to medical error, 1:300 only, which is a very disappointing, I think. But maybe
Sorry, sir, your voice is not very clear, Dr. Prem.
1:300 mortality out of medical error only. So this seems very, in general it seems exaggerated, but maybe true. 2016 data.
Yes. Somebody else would like to give an attempt? A last chance? So why I have given, okay, I take it up. So why I have given this three picture is a plane crash. Everybody was frightened about after the Ahmedabad crash, right? Yes, we were no, we were very, very frightened. And in fact, after that, when I boarded a flight after 2 weeks, I saw everybody, it was pin drop silence. All the children were asked to keep their mouth shut, and they were everybody was praying. So I could see that scareness in the air actually that time, which everybody would be, right? A car accident, which is 1 in 5,000, and this medical error. So when we think of risk, we only think about the events like, if what if I die in a plane crash, or what if I die in a car accident. But statistically, the odds of dying in a plane crash, and it's about 1 in 290 million. The statistics of dying by the car accident is 1 in 5,000. But now, when you are actually comparing it with healthcare, the medical error is estimated at 1 in 300. This means the patients are actually facing a far, far, far greater risk inside the hospital than on the airplanes and on the roads. Right? Here we are actually the top of the pyramid, which is the voice of the patient, is actually not at all taken into account. And we are now this is why it is now getting highlighted that patient safety and error prevention must be our top priority. And this emphasizes the importance of patient safety, error prevention, and a very, very strong clinical governance in the healthcare system. So what we have actually been doing is we are actually rather frightened with all other possibilities, but we are actually neglecting the medication errors that is actually happening around us, right? So how do we actually, you can see there is a scissor over there, right? This is a medical error. But many times, this case was in the John Hopkins Medicine Law, and this was a leading cause in the US. Here in India, there might be any number of such cases, but for all you know, none of us are aware of it. So this is the reason why actually the PREM, PROM, and the culture of safety has seen the day. Moving on, now linking the PREM and PROM to the risk reduction. An example. A hospital PREM survey shows that 40% of the patients did not receive clear discharge instructions. What happens? Patients are always in a hurry. Once they know they are getting discharged, they want to go back home. And to go back home, what they see is they need to make the payment, and they're always desperate to go home. The discharge advice is not explained many times. The many hospitals, they do not even issue you the discharge summary. They say when you're coming for review, you can take it that time, which is actually wrong. We have to give the discharge summary to the patient at that point in time. And you have to, basically, many hospitals, I do not want to take the names, many group or other chain hospitals are also actually just come and take the discharge summary when you are coming, unless the patient is a literate patient or an educated patient and he files for the discharge summary and he wants, okay, you have to give me the discharge summary right now. Nothing happens. If it is an insurance patient, that time they will upload the discharge summary. Otherwise, if it is a cash patient, they really do not. So why did the patient not receive clear discharge instructions? Because there was no discharge summary. The doctor only wrote the discharge medicines, and that prescription was handed over to the patient, and the patient left. What results because of that? A lot of miscommunication. Because of this miscommunication, medication errors. Doctors will write in small handwriting, they will scribble something on the paper, some will write the generic name, some will write the brand name. That brand name is not available when you go outside the hospital, and any number of reasons can happen. But this is actually increasing your medication errors. Now, what action should one take? Introduce a standardized discharge checklist, reduce readmission and error risk. Now, what happens? Discharge checklist everybody has. Discharge summary everybody has. You have to incorporate it in your policy that no patient gets discharged from the hospital without getting the discharge summary. Now, this is an example of an experience a patient has had in the hospital. Now, how about the outcome? Knee replacement. You have done a knee replacement. Patient comes for suture removal after 7 days. Suture removal is over. That's it. Nobody is bothered whether he's coming for physio, whether he's doing a load bearing exercise, or whether he's doing a non load bearing exercise, whether he's using the stick or the stretchers. Nobody is bothered. This is actually wrong. Now, how can you measure the outcome of this? After knee replacements, you actually have a follow-up call with the patient. Call that particular patient after 1 month, call that particular patient after 2 months, then after 3 months, and then after 6 months, and tell the patient, please come and visit the doctor after 6 months. Nothing else. The patient is walking very fine. But just that, whether the patient is having any pain, whether he's having any cracking noise when he or she is sitting and standing, all these data actually are used and can be used as benchmark post surgery. For a one patient, you might have discharged him with a PAC machine because he was having unbearable pain. But other 10 patients, you have not done that. So that 10 patients getting discharged without a non-PAC machine can be used to revise a protocol and redesign the protocol or revise or actually better, set as an example to the other TKRs. A paper might be published on that, considering if only you are following up with a particular patient. Sorry. So a follow-up, an outcome, the follow-up of that particular surgery is what is actually important. And poor functional outcome despite clinical success is the risk that a patient has. Tomorrow the patient has gone. The patient is again, hesitating to come to the doctor because he might be having terrible pain and he might be thinking that the doctor will again do some procedure and again my pain will increase. So he might be just taking paracetamol. What it is, it's a wrong thing. It's a functional outcome which is actually wrong. And because the hospital is calling, because that particular department is calling, or because that the patient care manager is calling the patient and finding out, he or she also gets aware. And then you can tell them, okay, after 3 months, look out for the sounds. You remove your stretchers, you remove your stick. After 3 months, just walk straight. Do not walk, do not do brisk walking. Just 1 minute. So that awareness can be given on the call, and that's actually going to improve the outcome of that particular knee replacement. Now, how hazardous is healthcare? WHO estimates 1 in 10 patients are harmed in developed countries. What is happening actually? Now, if you see this graph, there are many patients who are having difficulties during bungee jumping, mountain climbing, and all those, God knows what all. So, healthcare is actually to heal. Here, according to the WHO studies, 1 in 10 patients are actually harmed during the care. Now, what type of care? It can be any care, and it can be in low income group countries or middle income group countries, anywhere, because it is very, very alarming that we are not able to prevent the healthcare. We are not able to prevent how things are actually emerging. And that is why strengthening the patient safety systems is not optional. Rather, it is very, very urgent. Because you see, 100 people die from unsafe care. And more than 50% of these harms are actually, if you sit and do a retrospective audit, you will understand these could be prevented. But why this happened? Because there was nobody to capture the experiences, nobody to capture the outcome. The patient came, patient got the treatment done, patient went. It's just like one vicious cycle or rather a chain reaction that people are coming and going and nobody knows what's happening. So it's actually very, very alarming when you read these news. I will be sharing this PPT with you. There are a lot of links that I have mentioned over here. Kindly go through that, refer, and you will understand how serious it is. And in such serious situations, what is the need of the hour that we actually need to incorporate in our organizations. Now this, you must be wondering, this is a picture of Sri Devi. Can anybody tell me why have I put this picture of Sri Devi out of nowhere? Not that I like this actress only. There are many more reasons to it.
There is a medical negligence in her mother's case, where I think she was operated on the wrong side of the brain.
Very true. So, she was operated in the wrong side of brain. That means those days they were not using or referring the surgical safety checklist. Right? There was no surgical safety site marking before the patient was actually wheeled into the theater. There was nothing that there was done. There was nothing that was actually done to incorporate any prevention or any mistake or any double check that was not happening. This actually will remind you about the patient safety. And this is not only about the statistics. Why do we remember about Sri Devi? There might be any number of such incidents which might have happened. Why do we remember about her? Because she was a famous personality then. But when her mother underwent brain surgery, it was a shocking error. It was a case of medical negligence, as Sir rightly said. But this actually made the light in the global headlines. And which is why many people, not only this case, but many people sat down, did a retrospective audit, and found out, along with WHO and other global bodies, that we should actually prepare a checklist which will prevent a wrong surgery to the wrong patient at the wrong site. Right? This is actually a never event. This should have never happened. And if such errors occur in the advanced healthcare system now, we actually need to sit down, pause, and reflect as to where is our country heading and where are we heading. Here, nowadays in hospitals, we do a surgical site marking with the marker, we do a surgical safety checklist marking, we also, circle down. The Excel films are gone inside the theater for the doctor. We again cross check with the patient, left or right part, left knee, left hand, right hand. So there are an n number of ways where we should actually check. So this is a classic example that the healthcare industry needs to have a very, very high alarming signal to understand the patient's experience and the patient outcomes to establish a culture of safety and a culture of quality in our organization. Right? Now, the examples of PREM and PROM. This is one example, the wrong side, wrong surgery, which I have already given you. Now we move on to the next, which is outcome. Here, after a brain surgery, the scenario is after the brain surgery error, even if corrected, the patient may continue to suffer from neurological deficits, pain, or reduced quality life. Now, how will you put PROM into the picture and how will PROM be helpful? Here, with PROM, which is the outcome, we actually can get the patient's actual health outcome by doing a treatment beyond what the doctor's reports are actually saying. So we actually need to have prompt to redesign the follow-up care, to redesign your rehab practices and have an accountability. If the patient is coming to your hospital and you, in the discharge summary you are writing, there will be a follow-up call. And once there is a follow-up call, the patient is expressing the complaints. If there is any complaint which can be addressed by our healthcare workers, we should definitely call back. This is why earlier we were taking feedback, but that feedback was just retrieved with us only. We were not sharing the feedback with anybody. We used to get the feedback forms. It'll be stacked one after the other, and it will be kept in one corner. Then we started having our Google forms. So what happened? You have the Google form. Nobody's analyzing that data. Nobody's giving any statistical analysis. Nobody's preparing any report of the feedback. It is just going. Nobody's actually acting on it. But with PREM and PROM, if you are actually capturing the details, you can save n number of fatal errors which can happen. Now, this is another picture. So, can somebody tell me why is the safety culture in developing countries important and how are you actually going to link it with the PREM and PROM? You can see one train. You can see a train with multiple people. You can see another train where people are there in the near the window, and one two-wheeler with any number of people. Yes, can somebody interpret this slide for me, please?
They have not realized what would be the outcome, that how risky it is, that they are risking their life just for the sake of, maybe it could be an exam related thing that they have to reach to exam, but that for that exam they are risking their life.
So how do you actually get it into the healthcare scenario? This example I have given where they are risking their life, I agree with you, but I want you to relate this with our healthcare fraternity, or rather what we are actually doing in a healthcare industry.
So sometimes like doctor suggested the person or the patient that this is the proper management, that you need to go for a surgery thing, but then the patient feel, no, I am good enough. They are just trying to make money of it and they don't want to. And later or sooner they have that the disease has progressed to the end stage and nothing can be done at that point. So earlier, if they have took the advice as a medically, so then they could have cured the disease in the particular manner and they could have a good recovery period.
Good attempt. So just as
Many
unsafe
of
travel
the
practice, yeah, sorry.
many of the health systems are overwhelmed and they do not have adequate paramedical or social workers to explain the whole process, which I think the support staff are not adequate in Indian system, in at least in the government sector. That's what I thought.
Ma'am, there is no awareness of the culture being in the organization. So if we start implementing the organization from the operational level to the top management, then this is what the culture safety can be built and everyone will become aware of the safety culture.
Correct. Very true. But now, nowadays, there is a culture of safety which is actually getting established. But as you said, we do not recruit sufficient staff. So private sectors, they will think of, saving the money, because if they have an extra number of staff, they will have to pay extra. In government sectors, again, staffing is a problem all across. That is one bit. Yeah. Sorry?
Hello?
Yes, ma'am. Okay. So just as the unsafe travel practice is reflecting on the poor culture of safety in the society, similarly, why I have put this picture is unsafe healthcare practices reflect on poor patient safety culture. So here you see there is a safety culture because in one two-wheeler there are 10 people going, right? The train on the train there are many people traveling. It is actually risky. But the similar thing is there in our hospitals also. We are not at all using the safe healthcare practices, right? This is where PREM and PROM actually becomes powerful. Now again coming back to PREM, patient reported experience measures. They help us capture whether the patient is actually feeling safe, secure, respected, cared during the treatment, right? With the patient outcome, we understand whether that treatment quality or the treatment is actually improving the health care of the patient or improving the recovery and the quality of life of that particular patient. So if the patient reports negative experience or negative outcome, it is a signal or a warning to us that we are unsafe. Can you please mute yourself? Request everybody to mute yourself only when you're talking. If you can unmute, it will be good. Yeah. So if we are actually getting a poor outcome or if the experience is bad and we are capturing it on a daily basis and also benchmarking according to our hospital and the other international standards, we are actually trying to give or improve ourselves and give a better outcome or experience to our patient. So with PREM and PROM data in hand, the hospital can actually identify the risk that are anticipated early and correct the unsafe practices which is happening in the organization on a daily basis. So PREM and PROM, here in this picture, I'm trying to relate the PREM and PROM with the culture of safety in the hospital, whereas these pictures are actually showing you the culture of quality and safety on the road. This is by our choice, right? Here, a patient is climbing on the train, it's his choice. not a patient, I'm sorry, a passenger is climbing on a train, it's his choice. But when he or she is coming to our hospital, and when he or she is treated, and when he or she is not able to have a good experience or a good outcome, it is our fault, right? That's the correlation between patient experience, patient outcome, and this safety culture in the developing countries. Right. Moving on to the next slides, linking the safety culture to PREM and PROM. So this, whatever I have explained you, I will take you through the slides now. So experience of the patient is basically reporting overcrowding, delays, and poor communication, and highlight the unsafe policies or processes like patient flow, hygiene, consent. So if we have 30 beds, and if your general ward is with 15 beds and the other 15 are private, in that 15 beds, if during a disaster or tomorrow the patient will get discharged, today itself that nursing home has admitted some more patients, that's wrong. The experience of the patient goes down. You are overcrowding. Then with overcrowding, what will happen is you are having a 30 bed in the hospital, but if you are admitting more than what actually your capacity is, your staffing is a problem. Then the duty doctor's communication is a problem. Then the number of restrooms are limited, so hygiene is a problem. And then you are in a hurry of shifting the patient one after the other from the surgery or to the surgery. You are not getting the consents filled. That is again a problem. How will that affect the outcome? Errors will happen, infections will happen, poor recovery will happen, and the patient will actually have pain, will be disabled, will express disability and reduced quality of life. So, PREM and PROM with the culture of safety is actually experience of unsafe systems and outcome of unsafe systems. So, safety, PREM, PROM, it's all interrelated. There is not that culture of safety separate where you are only doing your AHRQ scaling and PREM is different and PROM is different. These are actually all interrelated. And end of the day, they all talk about patient safety and quality. Now, what is the difference between PREM and PROM? Very quickly, I'll take you through this slide because I have been explaining this time and again. It's experience measures, outcome measures. Here in PREM, it focuses on the experience during the care, and in PROM, it focuses on the outcomes after care. Measures are communication, empathy, respect, responsiveness, and the environment when the patient is in the hospital. Outcome is pain relief, mobility, mental health, and the quality of life. Timing is collected, when is the PREM collected? During or immediately after care. And when is PROM? After the recovery or the treatment period. What type of questions do you actually frame your checklist as, or you go and ask the patient or your Google form or whatever measure you are having to capture? What are the questions you will have? You will have to have open-ended questions like, did the staff explain you things clearly? Were you treated with dignity? Were you treated with confidence? Were you treated with privacy? Was there all the patient rights should come into the patient experience? And in the outcome, you will have, can you walk without pain now? Has your quality improved? Are you able to sleep? Or I hope the stitches are healing and you are not having itching. So whatever it is after the quality of the care, after the patient is actually discharged and gone. Purpose is to evaluate service quality and patient safety and patient satisfaction. It evaluates your clinical interventions. If the patient is having any other itchiness or discharge from the wound or not able to walk properly, then you actually intervene clinically. So that's what is PROM. Then use in healthcare. PREM is used to improve patient-centered care and service delivery, and PROM is to assess treatment, impact, and support value-based care. And PREM together provides insight on how care is delivered, and here it provides insight on what care actually achieves. So what you have achieved after a particular care that was given to you during your hospitalization. So this is a very basic difference between PROM and PREM. Now, we've been just talking about PREM and PROM. So how are you actually going to implement it in your setting? So it's like a flow chart, but I have elaborated it with examples. So I've not made it as a flow chart, but it's a very, very synchronized process. Select a validated tool. You have to select which PROM you want to actually capture or which PREM you actually want to capture. Then select the area. So like NABH or any accreditation body would say, you need to have all your forms and formats which are actually bilingual, right? So why do we say bilingual? Because if the patient is not able to understand, he or she might actually see the translated version or maybe pictorial as well. So ensure the cultural and the linguistic adoption. If you are in Tamil Nadu, you need to have English and Tamil. If you are in Maharashtra, Marathi and English. If you are in West Bengal, Hindi, English, Bengali. So three languages. Staff orientation. You have to train the doctors, nurses, or whosoever it is as to why PREM and PROM actually matters, and you have to clarify the rules. What is the role of a staff when he or she is capturing the PREM data, and what is the role, the role of a staff when he or she is capturing the PROM data, and who is actually going to sit and analyze that. So you have to identify the rules, or rather make a committee out of it. Right. The next is patient data collection. How are you collecting the data? It's in the feedback form, or it's in the form of a discharge checklist, or it's in the form of a kiosk, or whether you will send a feedback or a Google link, like how you had your pre-test link. So, whether you will be having the Google link, whether it will go in the form of poll, whether it will go as a message, or it will go on your email, whatsoever it is. And inclusivity for low literacy patients. So, you can have audio prompts, or you can have those pictorial sites. So that's up to you. You can design it on your own. Data validation and analysis. This is the most crucial thing. How do you actually validate the data? Remove all the duplicate entries and then sit and capture the data. Prepare mean, median modes. Prepare some statistical analysis. Prepare some graphical representation, and then present it to your committee. Reporting via dashboards. This many software people have now, along with the quality indicators, started having dashboards also for PREM and PROM, right? So in the dashboard, you will understand which department's PREM is actually high and which department's PROM is high, and you can actually reward the department if you're doing it on a regular basis, or reward that particular staff also in that particular department who was the HOD or something like that. You can develop any mechanism on your own. Then action plan is your root cause analysis and cover. Like any quality indicator, you are capturing the data, you are sitting and analyzing the data, and then you are finding a root cause analysis as to why this happened, and then you're developing a corrective action and preventive action about it, right? Then the feedback loop and patients for the patient and staff. So whatsoever were your findings, whatever were your root cause analysis, whatever corrective action you had, whatever preventive action you had, share that with the patient. I'll tell that with the, because if once he is a patient of your hospital, most likely he will be again visiting your hospital in the next 2 months or 3 months. So you can tell your reception, or you can leave a note in, if any software, if you are maintaining that sort of a software, you can just leave a note over there and just write over there that when this patient comes, I need to meet this patient. And when you're meeting this patient, you share the feedback that you've actually had and whatever improvements you have actually developed after receiving his or her outcome or experience. They will be happy and they will also be motivated. They will be the word of mouth for you to send another 20 more patients, right? So the feedback loop to the patient and staff is very, very important. It motivates them to fill the form, because the form that you must have sent must be very, very exhaustive. And he must have really gotten irritated with filling up all those data. So when you're actually telling him that, you look, this was the experience when you were here, and this is what we have actually done to give you a better feel. So this is the before, or maybe you can give them a before and after picture and say that this is what it was when you were admitted, and now this is what it is. So he or she will actually feel motivated. So this what I have actually told is how you will be implementing. Now, the another key thing that you actually should or can implement is, you can do the prems and proms departmental specific. A prem of an OG department will differ with that of pediatrics, will differ with that of general surgery, and will also be differing with that of orthopedics. So sit down as a team, as a multidisciplinary team, and you can make your own prems and proms and validate them, review them, and then print it or have it in the form of a Google form. Do not have a similar prem and prom for all the departments, because what is relevant for an orthopedic department will not be relevant for a gynecology department, right? Now, how are you actually going to implement prem and prom in the clinical settings? Clinical settings, to actually imply the clinical implication of the PREM data is actually entirely on the accessibility and the respect and the coordination and the communication that you are providing for that particular patient, right? This is the experience, and this is how they will reshape or they will they will reshape or have the insights that they are actually going to happen and how is the care getting delivered. If the patient gets admitted on day one, if he or she has had a very nice experience with that particular duty doctor when he came for the initial assessment, that that very day he builds a sort of confidence that okay, this duty doctor when I came to the hospital has actually spoken to me well, gotten all my history properly, so I'm sure he will be feeling understood. So that patient will be sure that tomorrow when his surgery is going to happen, unlike the doctor, everybody will also be so reciprocative, right? So patient providers communication or the patient's first, we say no, the first experience should be the best experience. Similarly, when the patient is actually coming to the hospital for the very, very first time, how you are actually addressing that patient carries a lot of impact in his or her mind, right? The clinical values will now come from these insights reshape the way the care is actually delivered. Now, improved patient-provider communication. PREM identifies whether patients are feel listened to, understood, and respected. A clinical a clinician can adapt consultation styles, use simple languages. If you are using hypertension, many of the tier 2 town or tier 2 or 3 cities will not know what is hypertension. They will know BP, or they will know pressure. Okay, they will not know hypertension. They will not know what is hypoglycemia. They will not know what is COPD. If you say you have COPD, what is COPD? They don't know unless you tell them what is actually a COPD and you tell them in the local language. So you need to make the patient be respected as well as feel felt understood that whatever you are telling he is following or not, right? Clinicians should talk the simplest of all language and keep the patient in one part of in each and every part of the decision making. Example, if a patient reports difficulty in understanding discharge instruction, hospital can introduce visual aids or follow-up calls. How will you introduce follow-up calls? You might I'll just give you an example where a patient is going to just see SOS written. Peptaz injection, Peptaz SOS. Right? What do you mean by SOS? What is INJ is flying somewhere and Peptaz is flying somewhere else? So they don't know. So you can call and inform them that you can have a picture of that, call and inform them that this injection is only required in case you have all these symptoms. Okay. Or rather, if an antacid medicine has to be taken, this medicine has to be taken half an hour before the food. And the next day, you can just do a follow-up call. It's all about calling and making the patient on the opposite side feel comfortable. That's about it. That's it. The clinical implication of PREM, again, everything, trust you to have confidentiality, do not share anything with anybody else. Give them the greater adherence to the prescribed therapies that you are actually doing, right? Cancer patients reporting empathetic communications are more likely to complete chemotherapy cycles. You have to actually show empathy. Please understand when a patient is coming to a hospital or when a patient is coming to a clinic, he or she is not coming with any will or any whims or fancies. They are coming because they are in pain. You have in with empathy, you have to talk to them, and that's how you actually develop trust and engagement with them. Right? Service quality enhancement. How can you actually enhance the quality if the patient has come as a review patient? Have a separate review counter for them. Ask them, you can just straight away come here. Avoid them waiting for long hours in the OPD. You can say for review, please come to this room and the doctor will see you directly. Okay. And the clinicians can collaborate with the administrative team to see how to streamline the patient flow. So this is our internal purpose, but the service quality has to be enhanced. Benchmarking human-centered care. Okay, so here you have to have a comparative analysis as to what are the benchmarks for the clinicians, for the different departments, and for the institutions. And then with that, you measure your own data. Do not try to measure data from the US, to that of in India. It will never, that benchmarking will never be able to achieve. You can start the benchmarking by doing it from an organization which is higher, or take the benchmarks which are the vetted ones or the validated ones, right? Accreditation and policy compliance. Many regulatory bodies are now requiring patient experience data, which I told you, and NABH requires, JCI requires, NHS also requires. So use your PREM evidence to demonstrate the alignment that you are having with the quality and the value-based healthcare models. The clinical implications of PROM, which is the outcome. It is actually only and only outcome focused. In PREM, you will have 10 other reasons, but in PROM, you will have very simple. The symptoms, the functional outcomes after the intervention is done, right? So how are you going to measure it? With the quality matrix or with the clinical matrix only. Example, a knee replacement may look successful on X-ray, but PROM will tell you whether the patient can walk pain-free. So that that answer whether the patient is able to walk pain-free is only by calling the patient. Right? I will give you an example. My mother got a bilateral knee replacement done in one of the renowned hospitals in a small town, okay, in a three-tier town, in a small hospital in the month of May. After that, I just immediately discharged her and I took her to Bangalore. Right? So when she was there in Bangalore, the very seventh day, I'm sorry, this just went away. Yeah. The seventh day, we get a call from that hospital saying that you are supposed to come on the 11th day for suture removal. What time are you coming? So she was in pain and she never wanted to go. She was like, let me do it here, to travel again and sit after the knee replacement, to travel again to that small town. I'll mention the name of the town, that's Vellore. So to again travel from Bangalore to Vellore is a hassle. I will do it here. Don't you have anybody in Bangalore? I was not comfortable then because I was very comfortable with the hospital in Vellore and I was staying there. I recently shifted to Bangalore. So that was one part. Then the 10th day she got a call. Madam, what time are you coming tomorrow? We will have the doctor see you in the minor OT where your sutures will be removed and your dressing will be changed. So that gave her a little confidence that she can just straight away walk into the minor OT. She need not wait into the OPD for a long waiting hours. After that, the suture removal happened, everything happened. She came back home. Then exactly after a month, she got a call. Madam, we hope you have stopped your pyrogesic. Do you still have pain? So she's like, no, I don't have pain, but today is the last day where I'm taking the medicine. No, madam, you do not have to take that medicine. In case of severe pain, you take it. Otherwise, you can leave it because earlier the doctor had advised to take it twice a day. So she said, unless you have pain, do not take it. And then she said, okay, can I have a video of how you're walking now with the stick and one with holding somebody's hands, and try walking the staircase and give us 3 videos. So she happily took the 3 videos and she was very happy. And then immediately, once the video went there, she told me to call the doctor and find out whether the way she's walking, is she limping or is it okay, or is it what was expected out of her. So here, this is when the patient is actually participating in the outcome. The patient is comfortable, right? The third month, again, she gets a call. Are you walking? Is there any cluttering sound when you're sitting or when you're getting up? Or are you having any upper thigh pain, or are you having any calf pain? So all these are open-ended questions which are asked. The whole reason why I'm quoting you this example is earlier, I was actually pushing her for the knee replacement, but now when it is over and she's able to walk fine in the last 3-4 months, she has recommended it to 2-3 other people that initially it will be pain, but gradually the outcome is good. You can walk. You don't have to wait for somebody else to come and lift you up. You can walk on your own. You can walk straight. There is no problem, except you don't have to sit on the ground. Now she is trying to convince 3-4 other people that if you're having so much of knee pain, you better go for knee replacement. So that's the impact when I had to actually push her that you have to get it done because her knees were getting curved, right? So below the knee and the calf, I could see a big bracket that was actually formed. So it was important for her to go for knee replacement. So that's where your the whole idea shift. That's where when your outcome is actually good, you are able to. It's a feel good factor, and the patient can actually, you know, be very, very happy with the outcome of and share the experience and outcome to the others and motivate them as well. Right? So this is this is measuring treatment effectiveness beyond clinical metrics. Then personalized care planning. Personalized care planning is post-treatment functional status, guiding rehabilitation, and again, tailoring the physiotherapy needs as per the patient's requirements. So any sort of rehab for me will be different from that of you. So every individual has a different pace at which they are actually going to recuperate after the illness. So, how are you doing? It's a different thing. There might be a study where you can have, okay, 10 fall under this category, the other two fall under this category. So then you can do a root cause analysis and kappa and find out what is it that is different between these 10 who are able to recover as per the expected outcomes, whereas these two are not able to. So then you can further do a root cause analysis. Then early detection of deterioration. Declining PROM scores may indicate worsening disease or making clinical marker rise. Example, PROM-based fatigue scores in renal patients may flag early anemia management needs. So this PPT, as I told you, I will be sharing with you. These are some of the examples. Now you can have examples as per your own hospital setting and as per your own departmental settings, rather, to be more specific. Shared decision making, as I've already told you, shared decision making between aggressive and palliative regimes, how you are actually going to you actually what bar you are doing in your consent forms. That's the benefits, yeah, alternatives and risks involved will all be with the shared decision making between the doctor and the patient. Population health and risk stratification, again, aggregated PROM data may identify groups at higher risk of poor outcomes, and here where the clinicians can prioritize what sort of baseline health scores are they going to actually capture. Evidence for research and value. This, as I told you a number of times, the real world evidence we take, we we do a data analysis and then we publish this as research or actually use it for our own settings and then make them a cornerstone of value-based models. So once you are doing this, you can then time and again change your SOPs, time and again change the way you've been working, time and again change the protocols that you have to follow for those particular patients. So here are a few case studies and real world examples of the use of PREM and PROM, and I have been very specific with just the Indian setting. The NABH, as I told you, they mandate the collection of patient feedback as a part of the accreditation standard. It is in one of the standards where they are actually focusing on the areas like communication, the staff behavior, the waiting times, and overall satisfaction. And this must be used for continuous quality improvement. As I told you, if the experience and the outcome of the patient in the initial 6 months of you starting or developing the checklist are not up to the mark, you have to sit as a team, revamp the checklist and use open-ended questions related to the experience and outcomes. And also check why the experience was not good, why the outcome was not good, tally that, measure it, and then implement. Please remember, what is not measured is not monitored, and what is not monitored is not measured. So you have to do both the things, that's measuring and monitoring at the same time. Now, PREM in discharge planning. Many Indian hospitals use PREM to improve the discharge process because discharge turnaround time, if you see, will be hours together. It will be 4 hours, 5 hours, 6 hours, where you're getting the clearance from the laboratory, getting the clearance from the ward, getting the clearance from the pharmacy, getting the clearance from the ICU, getting the clearance from the OT. The patient has not made the payments. So, PREM tools to improve the discharge process, to get the clarity of instructions, get the clarity of the post-discharge care, get the clarity of the medications to be taken after discharge, get the clarity in case of emergency symptoms, where to contact, whom to contact, and the responsiveness of the staff is the first and foremost, but it is mentioned at the last because it is the staff who is going to do all these things for you. And then, last but not the least, patient-centered discharge protocols, which is your feedback. What time was the discharge announced? What time did you get the discharge summary? What time did somebody come and explain you about the discharge? Nowadays, one of the good practices that the hospitals are doing is they are writing over their discharge summary explained by, explained to, and the time and the signature. So that tomorrow the patient cannot come and say that discharge summary was not explained to me, and tomorrow the nurse just can't come and hand over the discharge summary and run away. Right? It's good for both. Then PROM in Ayushman Bharat monitoring under the Ayushman Bharat Pradhan Mantri Jan Yojana, PROMs are being piloted for outcome-based monitoring. So many people are getting admitted under the PMJY scheme. So what are they actually doing? Outcomes are monitored, focusing on recovery, pain relief, and the quality of life, and actual patient health improvements. This is actually a big game changer. Once this PMJ is going to be, then all the state or rather all the government insurances will be abolished, and this will be the single key factor linked with your hour number. And I think that's going to be a big game changer, but yes, waiting for it to come. Right. Now the impact. The impact is again encourages hospital to go beyond clinical metrics and focus on patient-centric outcomes, build accountability and transparency in India's healthcare system, and support the shift towards value-based healthcare models in India. Challenges and best practices for PREMs and PROMs. What are the challenges? Low response rates, patient literacy barriers, digital divide, and staff resistance. Because staff will feel if I am getting this and if the patient is writing my name, I will be penalized. Digital divide. Many people are digitally or AI is a huge boon or a bane here. I will not go into that details, but yes, digitally it's going to affect you. Patient literacy, patient might not understand whatever you have written, which means I have already told you, you can make it pictorial, you can explain it. Sometimes you can also record and have that as a recorded message. And the low response rate because the patients are, by the time they're getting discharged, if they have had good experience in the hospital and if the outcome is actually, if they feel that the outcome is good, they are happy and motivated. But if they are not, or if the bill is shooted up more than what they actually expected, you will have the patient becomes cranky and hence low response rates. What are the best practices? Have a 360-degree survey. That's a multi-channel survey in the form of paper, digital, SMS, WhatsApp, emails, whatsoever. Staff engagement and training. Sorry. Staff engagement and training. Train your staffs. Educate them about what is PREM, what is PROM, and why is it important. And tell them it's not going to be a punishing tool for you. It's rather going to improve the quality and the training and the transparent communication. As I told you, please come back to the patient and tell them this is what it was, this is what you had complained, or this is the feedback that you had given, and this is how we have improved ourselves. Be very transparent and continuous monitoring and feedback loops. Future trends. AI and digital tools, sentiment analysis on patient feedback, integration with the wearable health tech. Right? So nowadays you have those watches. So everything can be tapped on that. But nowadays many hospitals are also giving app to the patient that when you come to the hospital, please download this app. They come, they manage their own appointments, they manage their own payments, they manage their own the lab reports come into that patient portal. They manage the OT scheduling. Everything is on that particular app. Like how, you know, we are doing it for ourselves in the hospital. Similar is the patient portal. It was there earlier also, but if the patient is understanding the regional language, talk in the regional language. Use pictorial signs. If not, use the patient's relatives to explain to the patient and get the, record the feedback based on what the patient's attendant is saying. There you can write down received record. I mean, you can write over there as to that you have recorded the findings with the help of the patient's relatives, because you never know if the patient is saying something and if the relative is manipulating as well. Or you can have an interpreter, or you can have somebody who can actually, guide you as to what they're saying, or you can use a Google Translate. That's up to you. But you have to take down what the patient is actually saying. And best is, if the patient is not writing, please mention over there, take in the feedback from the patient's attender or from the patient's relatives or the bystanders.
Okay. I think with this, I'm sure we have more questions. There were, a lot of questions on, the various digital platforms, as you said. But I think it really calls for, maybe a follow-up session and so on. And I think, really sharing. But I think for everyone, there has been an overwhelming response in terms of, how people are really looking at and improving, their knowledge and ability to really take forward the important aspect of patient perspectives into outcomes as well as experience. And I think this was a great session, Meenakshi. I'm sure many people who have been listening would also be able to take up smaller studies at this, at their hospital, and start it more like, can we publish it? Can we really start really looking at it? So I think, it's a lot of, information, and we already have, telling in terms of really the response and the number of people who have been asking questions and sending us the questions. And I think, it requires a follow-up. I'm sure we will continue to look at it in terms of, if somebody wants to come up with a digital platform, do you want to, like, how is the research design going to be for this? And how do you really close the loop and make it into a routine practice? Because I think eventually that's what we want internally, that it becomes a routine practice for that. And I'm sure the case examples that you gave, especially where there is a lot of number of surgeries, rehab, especially with orthopedics and others, maybe, very specific, the starting point could be those. And I think overall it has been a great, session. And thanks a lot, Meenakshi. And we will continue to engage. And I'm sure, students of the program on certificate course on, health quality as well as patient safety part are also benefited with this, as well as the participants and the students of IIHMR and a number of people who have come in. And so we thank you profusely for this wonderful session. And we also thank all the participants to have been very actively, engaging and learning. And, I'm sure in some fashion, they're motivated to take it back to their workplace and implement. So with this, maybe I will get it back to Dr. Deepa for, she's already posting the questionnaires for post-test questionnaire. So over to you, Deepa, and maybe Pavitra. Yeah.
Thank you so much, both of you. It was a wonderful session and a good discussion indeed. And PREM and PROM is like nowadays it's important to know what my patient feels, right? So I think a good session and overall a very good discussion. For the participants, we have posted the post-test link. Kindly fill that. We are yet to give you the feedback link and the certificate. So please do submit the post-test. It's very important to know the effective part of this training, so and also your learning, right? So please submit your post test and keep me posted that you have submitted, so that we can move to the next on the feedback. And I would also request those who have joined us, if you could open up your video, we could take a picture together, and I think that would be a wonderful memory for us too, right? So I'm removing the spotlights now, and so that we can take a gallery photo. Yes, encouraging participants to enable their videos so that we can take a good picture. And I request my training team, Pavitra, Sneha, and Neeta, to take a picture of us, all of us, and participants keep. Yeah.
Your cheeks hurt, right?
Till your cheeks hurts, yes, ma'am. Yes, I think different pages we are taking. Right. Yes. I hope you all have submitted the post test along with this photo. And now I would request Pavitra to share the feedback link. So that, and by completing this, I think you would get your certificate on this masterclass on leveraging PREM and PROM for the quality this. Yes, Kiran, we will be posting the group picture in the WhatsApp group which we have created in the broadcast group. Yes, we will be doing that. Yeah. So your feedback is very important to plan the sessions like this, to plan the skill stations too. So please ensure you give us a proper feedback. And yes, and sir, Bajaj sir, you're putting 9 on 10. Congratulations, sir. Thank you so much for putting the details too.
Thanks, ma'am.
Yeah. I hope you enjoyed the session. Please give us a feedback. You can connect back with us for any other training requirements on quality and patient safety. Thank you so much, Usha ma'am and my team for organizing such wonderful session. And Meenakshi ma'am, you were great. And we will be calling you back again for different sessions too. Yeah.
Sure.
Thank you,
Thank
ma'am.
you, and have a great evening.
Yeah.
Thank you, ma'am.
Thank you. Thank you, Meenakshi.
Thank
Bye-bye.
you.
Bye-bye, everyone.
Thank you,
and
ma'am.
yeah.
Bye, everyone.
Thank you, ma'am.